News and Talk, WAOK Women's History Month series. Woman to Woman. Conversations with Juandolyn Stokes. Juandolyn sits down with Dr. Valerie Montgomery Rice, a distinguished leader in the field of medicine and education, who is an American obstetrician, gynecologist, college administrator, and the president and CEO of Morehouse School of Medicine. In this one-on-one conversation, we'll explore Dr. Rice's remarkable journey, accomplishments, and vision for the future of healthcare and medical education. Join us as we embark into the inspiring story of a trailblazer who is shaping the future of medicine and making positive impact on healthcare worldwide. A wife, mother, and the sixth president of Morehouse School of Medicine, Dr. Montgomery Rice is the first woman to lead the freestanding medical institution. She is a renowned infertility specialist and researcher who serves the community, advocating for health equity, developing African-American doctors in research, and providing quality patient care. She is the founding director of the Center for Women's Health Research at Meharry Medical College, one of the nation's first research centers devoted to studying diseases that disproportionately impact women of color. Dr. Montgomery Rice is in a unique position of leadership as an integrated member of the largest consortium of HBCUs in the world. And now, Woman to Woman, conversations with Juandolyn Stokes and Dr. Valerie Montgomery Rice.
Hi, I'm Juandolyn Stokes, host of On Point with Juandolyn Stokes, heard weekdays 10 a.m. until 1 p.m. on 1380 WAOK. And I'm inviting you to share with us right now in my Woman to Woman series. And my very special guest this week is Dr. Valerie Montgomery Rice. Hi, how are you?
I am doing well. Happy to be here.
Glad to have you here. Wow, you have had a long history of working, starting, creating, finding and founding different organizations. Tell us about that path and journey for you.
You know, it starts with finding your passion.
Okay.
And I have been very, very fortunate to be able to find my passion in the field of medicine, but it's always been about advocating for women. Mm-hmm. I was raised in a single-parent household with a mother who worked the swing shift 7 to 3, 3 to 11, 11 to 7, and she had 4 daughters. And she would come in off of that midnight shift, and it would be like 7:15 in the morning. You would be trying to sleep, and she would be whispering in your ear, "All things are possible. You can do anything." And no matter when she came in, she would do that. And my mother, now we're from Macon, my mother did not know what osmosis was, right, or subliminal messaging. But she knew that she could fill our heart with something.
Wow.
And I think that's where that opportunity to co-create with others began for me, because I think she was helping us to co-create a path for ourselves.
Wow, that's awesome. Mm-hmm. And do you think that gave rise to your sensitivity and pursuit of research as it relates to women's health?
No doubt about it. So I went to Georgia Tech as a co-op student in chemical engineering, and was co-oping. We were on a 10-week system, so every other quarter I was co-oping up in Cincinnati, and I was working on the kinetics of Tide detergent. And, I was really excited, not really. But I recognized that actually there was something missing in my passion for loving math and science, and it was people. Mm-hmm. But I did love discovery. Okay. Right. So I was doing chemistry work. I was discovering. We were looking at new opportunities, new technology, but the people part was missing in engineering for me. So I decided that I would go to medical school.
Okay.
And when I went to medical school, I thought I would be a neurosurgeon. So I went up to Harvard Medical School, and I said, I'm going to be a neurosurgeon. I carved that pathway, and then I did OBGYN in my 3rd year as my last rotation.
Really?
And when I did that rotation, I was like, okay, I like the GYN part of it, the surgery part of it, but I didn't want to be birthing no babies, as I thought in my mind, obstetrics. Okay. So I'm on the rotation, and I do my first delivery, and I still believe that this was a ploy. And the doctor who was supervising me was talking to me and talking to the parents about, how he had enjoyed me on the rotation. And the parents say, well, we're going to name the baby Montgomery. And they named the baby Montgomery, and I said, they're trying to trick me into this. And then I started doing the GYN component. And when I did the infertility part of the rotation, I recognized all of the research that was coming of age to help women and couples become pregnant. And so I looked at reproductive endocrinology and infertility, and that was the path for me. And so I spent the 4th year of my medical school, instead of going out to different places and doing rotations, I was actually in the laboratory looking at how we could purify hormones to increase women's chances of producing more eggs.
Right.
So that they could go through IVF or go through ovulation induction. And so I did that for 11 months, graduated from medical school, came to Emory for my residency training in obstetrics and gynecology. And the reason I chose Emory was because they let me bring my research with me.
Wow.
So I would be an intern working over at Grady, and across the street I had a research lab where I was going to inject my mice. So
Wow, that is amazing. That
Yeah.
is amazing. Do you see the numbers with women experiencing infertility still happening today? Is it still a major challenge?
it is
for lot
a
of
major
women?
challenge. You know, we always talked about the chances of a woman achieving pregnancy or having infertility, and you know, we used to think about, well, there's about a 15% chance that a person may have not get pregnant, and then when we break that 15%, when you really look at it now, 50% of it most of the time is a woman's issue, and 50% though is a man issue because of sperm challenges. And so what has happened is that we are much more aware and women are much more informed. And so we now also know that there are many diseases that women have, or challenges that women have, like fibroid tumors for women of color. We see more fibroids, which can impact your ability to get pregnant sometimes, and depending on where the fibroid is located, and also to maintain a pregnancy. So what we're beginning to see, and thank goodness for this, is that women are more informed. Providers are more informed.
Okay.
And if you are really passionate and in partnership with that woman, you all can make decisions sooner before they have to end up having IVF or some other type of more invasive procedure.
Are there some causes that women or couples may not be aware of to infertility?
Well, you know, we definitely have seen some environmental influences on sperm, which we didn't
Okay.
know for men. We definitely know that tubal factor infertility, if you had a sexually transmitted disease early on, and chlamydia, of course, is one sexually transmitted disease that women don't always have symptoms, okay? Or they may have a discharge and they don't pay a lot of attention to it, and it sort of goes away. But then when you have been trying to get pregnant for a year, regardless of your age, you definitely need to be evaluated. And there's some basic things that we do. We look at, do you ovulate? And we can do that with your temperature chart, but now there are a lot more easy tests that we can tell if you're ovulating.
Okay.
You definitely should have a procedure called a hysterosalpingogram or an HSG to make sure that your tubes are open. And then, of course, we need to test demand to make sure that the sperm count is there, that there's volume, that there's a number of sperm, and that they are moving in the right direction. Because you can have sperm, but they may not be moving in the right direction. And so all of those three critical things is part of that early evaluation. And what I say to women who are over the age of 35, though,
Okay.
you may only should wait for 6 months.
Okay.
And then you will start to have that evaluation.
Wow, that's good. And that's something that, certainly women need to know. And I'm glad you're saying that women are more educated and
Definitely
more aware. And that makes a major difference.
Right, you're right.
Talk to women about menopause.
Ooh, Lordy, that wonderful state of mind and state of place and space.
Yeah.
And what I always tell people that, first of all, menopause is an equal opportunity event.
Okay.
If you live beyond the age of 52.5 years of age in this country, most likely you're going to go through menopause.
Okay.
People always say, well, why didn't women complain about it early in the 1930s? Well, first of all, they weren't living that long.
Right,
So
that's
they
right.
weren't living long enough to complain about it.
Right.
Now, what we know is that menopause is a state where you actually have a drop in your estrogen level.
Okay.
That drop in estrogen level is most initially associated with hot flushes. The hot flushes are those warm summers that you have in the winter, night sweats. But then there are other things that women experience. Women experience vaginal dryness. Women experience bone thinning. And of course, we know that a decreased estrogen state is associated with an increased risk, we believe, of heart disease. And the Women's Health Initiative, one of the big longitudinal studies, showed us that women who had lower levels of estrogen had an increased risk of cardiovascular disease and heart disease. And so we know that it is a period of time that women are going to transition to if they live beyond the age of 52. The great news, though, is that we do have therapies that can happen. Hormone replacement therapy, while it can be challenging, and we have seen that in the Women's Health Initiative, we saw a slight increase in the risk of breast cancer.
Okay.
We know that that risk is very, very low, and but that protection for heart disease, particularly if women start it right at menopause when they're having symptoms, and take it for at least 3 to 5 years, we do see cardiovascular benefit. And remember, heart disease continues to be the #1 killer of women in this country.
And so is that why, though?
Oh, no. It actually is not why.
Okay,
Because of
okay.
the estrogen replacement that you give actually can protect. Okay. And there's not a 1-to-1 correlation that menopause is a direct factor for it. Is a confounder, as we say, because what we also see is an increase in weight gain. We also see an increase in high blood pressure and sometimes in diabetes also.
I see. Yeah. What are some of the other major things, health challenges that you find from your research that women face at various ages and stages of their life?
You know, for us, one of the things that we are really, really struggling with and continue to need to do much better job in this country is with maternal mortality.
Okay.
When you look at our maternal mortality rates in this country compared to other countries, first world countries, we are significantly more negatively impacted. We are actually at the level of some third world countries.
Wow.
And we know that particularly we see the gap in a higher rate of maternal mortality in women of color. And that is because they have higher risk factors when they are pregnant. Many times it's related to fibroid disease.
Okay.
And if you do not have those fibroids diagnosed and understand the risk associated with them, sometimes with delivery, you see more postpartum bleeding.
Okay.
And that is a risk factor, of course, that leads to a higher rate of death. But also black women, and particularly women who are having their first babies, tend to have a higher risk of preeclampsia, high blood pressure that occurs during pregnancy. And it occurs with, the typical story is that this is my first pregnancy. The woman gets to about 34 weeks of pregnancy, and they start to see swelling in their hands, swelling in their feet, and we start to then track them to see if they're developing preeclampsia. And once you develop preeclampsia, the only real treatment for preeclampsia is to get the baby out.
Okay.
So there's a balance between keeping the baby in long enough for the lungs to mature, but then delivering the baby in a timely manner such that the woman is not challenged. And so we have been on really a journey here in this country, in the state of Georgia, to increase the amount of surveillance for women during pregnancy, increase access, and then in the postpartum period.
Okay.
Because if you had diabetes during pregnancy, if you had hypertension during pregnancy, if you had preeclampsia during pregnancy, if you had any other maternal complications, how we monitor you for that next 12 months is critically important, not just to preventing your death in the next 12 months, but also your risk for heart disease and diabetes and hypertension further down the road. So we want to have this be a comprehensive educational journey, health journey for women with pregnancy. We want them to be as healthy as possible.
Yeah, that's right.
When they are trying to get pregnant. And during pregnancy, we want to listen to women and hear what they're saying.
Hear what they're saying.
When they are saying things that they have not experienced, it is not in their head.
Yeah.
It is actually in their body. And we as physicians need to be culturally competent and have enough cultural humility to listen to the woman and assume that if she's been living in this body for 30 plus years, maybe she knows something about it than you.
Right. And the key thing is saying culturally competent.
Yes.
Because in some cases, doctors are not culturally aware. And sometimes they're not even listening to what the woman says. Sometimes it's just all pain is just pain and you'll be okay.
Right.
Take this or that and you'll be okay.
So it is so, what I am so proud of at Morehouse School of Medicine is the diversity of our class, not just based on the race and the gender, but the experiences and the distance travel. So people come to us with different experiences, which means that when we are trying to become more culturally humble, we are able to listen to those stories and ensure that we are putting ourselves sometimes in the spaces and places across from our patients to make sure that we are listening to them and being able to understand what they are hearing when we're making recommendations to them. And then what are the other things that we need to wrap around those prescriptions and those opportunities such that they will embrace our recommendations. That's what cultural competence and cultural humility really is about. Are you able to put yourself in the background? And I always tell my students, ask a simple question based on who's sitting in front of me, what's possible. If you do that with every patient engagement, it requires that you put yourself second and their needs first. And it also prompts you to ask some basic questions. Well, can they actually get that prescription filled? Yeah. Can they actually afford to go to that specialist I'm recommending? Are they actually understanding the recommendations that I'm making? You got to ask the right questions, and you have to be humble enough to listen to the answer.
I like that. I like that humility part as well that you added to that. Talk to us about the origin of you, that moment when you knew it was time for you to step out and do something different. And now we have, Morehouse School of Medicine, you as president and CEO. When did that light bulb come on and say, okay, I'm getting ready to do something next?
I think the light bulb moment for me was my husband and I, who I met at Georgia Tech, and we've been married 32 years this year, and we took our first rodeo together in Kansas, and he was on a managerial track because he's an engineer also, and I was on the medicine track within academic medicine, and we were both being relocated everywhere, and we had gotten relocated back to Michigan. And we were in Michigan, and I had joined Henry Ford, and we had two babies who were 22 months apart. I think Jane and Melvin were 4 and 2 or something at the time. And I was working sort of 8 to 5. And I was working at an in vitro fertilization center. And I was working 8 to 5, and I wasn't doing night call and stuff. And my husband was excited, and I was bored to death. And I was missing my research, and I was missing teaching, and I was loving seeing patients, but I was missing that other stuff. And the chair of the department at the University of Kansas where I had left him a whole playlist or just a path of what he should do in order to find the right division head to take over the division. And he calls me up one day, and he says, I don't know that I can find someone who has all of these characteristics and the experience, Would you consider coming back? And I said, no. We've only been gone for a year. We're building a house. My husband likes the job. He loves the fact that I worked 8 to 5. And this is the time of fax machines because we didn't have the internet.
Oh, that's right.
And he said, write down what it would take to get you back on a piece of paper and fax it to me. And I did.
Okay.
And within 24 hours, he sent me back a fax and checked off everything. And I told my husband. And we said, okay. And then my husband called his company and said, we think we might want to relocate back to Kansas City.
Wow.
And they said, we would love to have you back there. And so that was it. And I became the division head of reproductive endocrinology at University of Kansas. I became tenured as an associate professor. And I then recognized that I actually had the leadership skills to actually do more in academic medicine. And I decided my first move from there, I went to Meharry Medical College and opened up the Center for Women's Health Research. I was the chair of the department, and I wanted to do something that would have an impact every day. And opening that Center for Women's Health Research, which was the first center of its kind that looked at diseases that disproportionately impacted women of color, sort of pulled together everything from when I was in that research lab at Procter & Gamble working on detergent synthesis to understanding that I wanted that connection of science and discovery with people, to the work that I had done in OBGYN, looking at purified hormones, to the work that I had done in IVF, and then understanding the differences, the disparities between black and white women in health outcomes, whether it was breast cancer or heart disease or diabetes. Then we needed to understand what were the factors that were contributed in that disparity. And it was more than just about science and biology. It was also about access, and it continues to be about access to care. It continues to be about our participation and availability for us to participate in research trials. And it continues to be about inclusion of us at the table where people are making decisions about healthcare resources and how they are distributed. And it continues to be about diversifying this healthcare workforce.
That's good.
Such that you have people who are sitting around the table who have different life experiences that can help you co-create more solutions that will apply to a broader group of people. So that was my light bulb moment.
Wow, that's awesome. And so when you established Morehouse School of Medicine, what was the overall vision that you had, and then the mission for it?
Now, let's be clear. I didn't establish it because it's.
But
50,
I know.
It's 50
but when
years
you came
old.
on,
When I came on, I did help some growth. I made some growth. So when I came in 2011. Yeah, 2011. When I came in 2011, it was a great opportunity for me the president then was Dr. John Maupin. Of course, our founder was Dr. Lewis Sullivan, was the first president and dean. And of course, we were founded through Morehouse College under the guidance of Dr. Hugh Gloucester, who was the president of Morehouse College. And my charge at that time by the chair of the board, Mr. Tony Walters, and then the president, Dr. John Maupin, was, we need to grow. When we were founded, we said we were going to be a class size of 100 students per year, and we've gotten stuck at 56.
Okay.
And so I worked with the faculty and the other leaders there that we went on a mission that within 5 years we would grow that class size of the medical school students from 56 to 100. We said that we would grow our master's programs, we would grow our MD, PhD programs, and our Masters of Public Health program. And I am proud to say that we met all of that. And what we did in between was we grew even more. So now our class size for the MD is 115 to 125 students per year. At that time, we had 6 degree granting programs. Now we have 16.
Wow.
We have a PA program. We have executive online programs. We have master's online programs. And we have just hired our first founding dean for our nursing program.
Wow. Oh, my God.
Our research portfolio has tripled in size, and our clinical operations continues to expand. And all of that is because we have a need.
Yeah, yes.
Georgia continues to have a significant number of counties that are underserved.
Okay.
And what we can show at Morehouse School of Medicine, that if we recruit students from underserved communities, there's about a 65% chance that they're going to go back and practice in those communities.
Wow.
They're going to choose primary care or core specialties. And so the state has been our greatest partner in helping us to grow our class size through increasing our state operating budget and being able to show them the return on investment. And so we've had great success, and we're looking for even more.
Wow, that's awesome. That's amazing. And so are you seeing more interest, even in the last, I would say since COVID, are you seeing more interest of Black and brown students wanting to pursue medicine, nursing, even the executive side of it?
Definitely so, definitely so. So Morehouse School of Medicine gets about 7,000 applications every year for 125 slots. I would say that 65% of all the Blacks and brown students who, definitely African American students who apply to medical school in this country, will apply to Morehouse School of Medicine. And in the state of Georgia, we see the same numbers. We see many students, Caucasian and non-Black students, of course, apply to Morehouse School of Medicine because they are in line with our mission.
Yeah.
They want to go into primary care. They want to be educated and trained in an environment that really is focused on culture, competence, and humility. And they also love the sites that we train at, Grady Memorial Hospital, the VA Hospital, CHOA, all of those great partners that we have, and in our ambulatory settings. That makes a difference. And they love having diverse faculty.
That's good.
That educate and train them, because they get to see what it means to have people who have different experiences to bring that knowledge with their academic knowledge to help them to become the best in class providers.
Wow, that's great. That's awesome. Now, a few years ago, when we were dealing with COVID, what role did you play in getting more of Black and brown communities to participate in clinical trials and research? Talk to us about that.
So, when I started the Center for Women's Health Research, one of my focus areas was diversifying the clinical trials.
Okay.
Because at the University of Kansas, I led the clinical trials division there. Now, Kansas is not that diverse, and University of Kansas was not that diverse.
Right.
But at that time, we were doing lots of clinical trials in hormone replacement therapy and third-generation progesterones that were looking at birth control pills and osteoporosis. And I, at the University of Kansas, on a regular basis, would win the awards from pharma companies, et cetera, for having the most diverse subjects in my clinical trials. And that is because I figured out that you needed a trusted messenger when you're going to go into the community to recruit for trials.
That's right.
I had a Caucasian nurse coordinator, I had a Hispanic, a Latinx nurse coordinator, and I had an African American.
Wow.
And they would go into those communities as the messenger about why these trials were important.
That was very smart.
That knowledge I've carried with me everywhere I've gone. And I am happy to say that it was already at Morehouse School of Medicine, so I could put it on steroids.
Okay.
So when COVID hit, the NIH and others reached out to us because of our track record and said, look, we see that this disease has disproportionately impacted communities of color. We need trusted advisors to have us to help enroll Black and brown people in these clinical trials so that we could understand how the effectiveness of these vaccines, and that they're not going to be different in Black and brown people who are disproportionately impacted by this virus. And so I'm proud to say my team there stepped up, and we were able to successfully enroll and met all of our enrollment criteria, and in many cases succeeded or exceeded it in the number of Black and brown subjects we were able to enroll in these trials, which really contributed to that vaccine getting developed and on the market a lot faster.
Okay.
But also, and most importantly, building the trust. I, along with Sanjay Gupta, we got our vaccine on air at CNN, and we were younger, okay? We weren't at 60-something, and people were a little bit concerned, but we felt that was critical to people's understanding that if we were willing to put our arm up there, that we felt that this was safe and effective. And thank goodness we did that, along with a lot of other people
I remember
who stepped up.
Yeah, yeah.
Because that gave the confidence. And then with blackdoctors.org and Doctors Against COVID and a host of others, we've done so many town halls, nationally, locally, to get the word out, how important it is that we participate and not just be a participant. But we participate, and that means sitting at the table, sharing our concerns, having people listen to us, and then being able to help co-create solutions. So,
wow.
and we were very proud that in the Atlanta University Center, Morehouse School of Medicine led the charge with the other institutions to ensure that we could get our students back engaged in the learning environment. And so we were testing every week, early on, twice a week, making sure that our students were vaccinated, requiring that our students were vaccinated, and not making excuses for that.
Right,
Holding
right.
ourselves accountable to creating a safe learning environment, because we felt it was very important that our students get back into the classroom.
Wow, that's great. That's great. And it happened.
It's
it
happened.
really did.
And now we're living with this as a, hopefully with something that will always be containable, because we have these new therapies.
That's good. That's good. What do you say to people who, get communication about participating in a clinical trial? Are there certain things that they need to ask about, or should they automatically kind of participate?
Well, first of all, I think they need to always ask questions, because
Okay.
first of all, they first should know that this is voluntary.
Okay.
And then they need to ask the risk and the benefits.
Okay.
And who will be the benefactor? Because not always in a clinical trial will you get a benefit.
I see.
There are many observational studies and longitudinal studies that we gather information, collect people's blood samples, etc., and they won't ever see the benefit.
Wow.
But people downstream, their grandchildren, think about the people who had to participate in the gene editing that went on with sickle cell.
Yes.
Some of those people have gone on. But if they could stand up and clap right now, they would say, oh my goodness, we have gene therapy now for sickle cell. And I contributed to that. And so what we try to make sure that we do at Morehouse School of Medicine, that we create transparency, that people understand that this is voluntary, and that they could ask as many questions as required for them to feel comfortable to participate. And if you go into a clinical trial and people say that's enough questions, then you need not be in that clinical trial.
I see.
Because
okay.
they haven't given you enough time for you to become comfortable. And you need to understand what's going to happen with my samples.
Okay.
Right? Who's going to have access to it? What are the privacy around it? Is it going to be used in a way that I'm going to be de-identified? So we are so proud that Morehouse School of Medicine recently got one of the 4 Grand Challenge Cancer grants.
Okay.
And our grant, led by Dr. Melissa Davis, a young lady from Albany, Georgia, who went to Albany State and got her PhD in the University of Georgia, and we recruited her from Cornell. We brought her back home. She's a cancer biologist who's focused on genomics. Okay. She is leading this, and our goal is to understand all of the focused areas in the genome where we can have an impact with cancer.
Yeah.
And her grant, along with 5 investigators in 5 countries in Africa, the UK, and the United States, is to look at cancer inequity. Our goal is really to create a new genome. The current genome that we use now, and it's so exciting that we have that, but it is only comprised of 2.4% African American ancestry.
Okay.
So while there's a lot of good targets that are identified and therapeutics that may come out of it, we always say, how precise can it be for precision medicine if it's not comprised of people who are diverse?
Right.
And so we hope that one of the things that will come as we collect 40,000 samples around the world, that we will be able to contribute to the genome and increase the diversity, not just based on race, gender, but also geography, where people live.
That's
What has
good.
been the environmental exposure over generations to your genome based on where you live, work, and play? We want to be able to contribute to that and then use that information to actually eradicate cancer.
Yeah.
We want to beat cancer.
Yes, we
do.
do.
We need to beat cancer.
Yes, we do. We
Yeah.
definitely do. Because aren't you seeing more numbers of all ages being diagnosed with cancer? I mean, at very young ages to older ages, onset, before COVID, after COVID. Are you seeing those numbers?
We are seeing that. Now, part of this is because the screening and the diagnostic technology has gotten so much better.
Okay.
And the great thing that I always think about is that we always have cells inside of our bodies that are mutating, right?
Yeah.
And now the question is, does that mutation get cleaned out?
I see.
It's when that mutation doesn't get cleaned out and is able to build on itself
Okay.
that you actually get this point that we think about, quote unquote, cancer, right? And so if I can detect that early, right, then I can stop that growth. Sometimes with extraction, moving it through a surgical procedure, but sometimes with medicines, which all of these new immunotherapies, et cetera, can send a signal, right, to those cancers and get to those cells to get them from mutating and to stop growing. And so one of the things that we're seeing is that our screening modalities, our diagnostic modalities have gotten to be so much better.
Oh, that's
so we're
good.
seeing early detection, but it also is having an informed population of people who are actually going to have screening and understanding that if I get screened and there's something bad that comes up, there's actually an opportunity for me to be cured. And that's what we keep focusing on every day. A lot of times early on in my career, I can remember when I was in my training and I would see women come in with breast cancer and it would be at a terrible advanced stage. And they would have known that it was there.
Wow.
But they ignored it.
Okay.
Because they did not think that there was a pathway for them to get better or to be cured.
Okay.
I think we've shifted that paradigm. We've changed that story because 90% of women will live through breast cancer. They will live through it. And it's because of the early diagnosis and the new therapies and treatments and opportunities that we can give them for, just turning it into, my opinion, a chronic disease.
Yeah.
That yes, I have to monitor, and yes, I may have to get therapy, but I can keep on with my life.
That's
Yeah,
right. That's
right,
good. That's
right,
good
right,
to
right.
know. Do you see any, as it relates to like medical insurance and people being able to pay for medical care, do you see that area kind of growing for communities in terms of being able to pay and afford medical care?
We continue to be challenged in this country with people believing, I think sometimes, that health care is a privilege and not a right. Health care is a right.
Yeah.
And if you are in this country, you ought to have, in my opinion, access to affordable health care. And in doing so, we need to make sure that it's accessible, right?
Okay.
So, when we had the Affordable Care Act happen, one of the things I kept pushing, guys, it's not going to be enough to just give everybody an insurance card. They got to have access.
Yeah.
And when they have that access, they got to have an experience that makes them come back. So again, that diversifying this healthcare workforce, making sure that we have locations and opportunities for people to have choice has always been important. There's no doubt in my mind that if we expanded Medicaid in this state, we would give increased access. And so it is my hope that the legislators and the governor will continue to work with the community, and healthcare providers are part of that community, to think about what are the ways that we can get to a point where every person in the state of Georgia, every person in this country has access to affordable health care. And it meets them where they are.
Okay.
And so we do see that over 40 states or 38 states have adopted Medicaid expansion. I still believe there's hope for Georgia.
Yes, there
and
is.
I'm going to keep advocating in the places where I have influence to talk about the why. But in the meantime, Morehouse School of Medicine is going to continue on its approach of integrated health care, putting ambulatory care facilities in places and spaces where there's challenges with access, partnering with our hospital partners to ensure that our providers are in those hospitals and in the communities providing culturally competent, culturally humble care.
That's great. That's great. Do you think that hospitals will grow even in the state of Georgia? Because we've had some of them to close in areas that we need hospitals to be.
Yes.
Do you foresee that hopefully we will have more hospitals accessible to communities?
I think so. We were definitely challenged with the closure of the two WellStar hospitals, and particularly from where they were located.
Yeah.
They were located in communities that were already challenged by access and the availability of the diversity of services that they needed to have care delivered to them, and in the manner in which they were closed in such short order, did not give time for all the preparation. Morehouse School of Medicine, in partnership with Fulton County Commissioner, we worked on a plan to really, I'm a scientist, so I believe in data.
Yeah.
And we were able to present data that showed that there were a significant amount of healthcare assets north Fulton, central, but not in the south. And even though there had been a lot of investments made in central Fulton where you see a lot of the hospitals,
yes,
that doesn't necessarily translate to meeting the needs of all of the persons in South Fulton. And so Fulton County partnered with us, and we were able to open up Buggy Works site near South Fulton Hospital, with the old South Fulton Hospital, which we believe gives another access point. You can see Grady starting to put some more ambulatory sites there, but that doesn't take the place of a hospital. So we were very, very pleased to see this week that there's been some changes to the certificate of need for the assessment of a hospital, some exceptions that are being put in place such that additional hospitals can be identified and created, particularly in those communities that have been disproportionately impacted by hospitals closing. So Morehouse School of Medicine is clearly looking at that and hoping to be a part of that solution.
That's good, and that's what you are. You're solution-driven.
I am solution-driven, and I love to do it in partnership with others.
That's good. Yeah, collaborations are great.
Exactly.
What is your message to women about taking care of themselves?
If you don't do it, nobody will do it for you. And for too long, women go through cycles.
Okay.
We go through cycles in our lives. We go through this cycle when we are young and we're finding out who we are and we're defining who we are. And then we get a partner and we decide that, okay, we want to have children. And one of the things I would always say to women who come into me and they would have an infertility problem, and I'll say, now, do you want to be a mother or do you want to be pregnant? That's two different things, okay? So you got to ask that question, okay? Because I'm going to steer you down two different paths. If you say you just want to be a mother and don't want to be pregnant, then that's a whole nother way we can help you with that, right? There are a lot of kids out there who would love to have your love, right?
Yes.
And so we find ourselves always being givers and caregivers, right?
That's right.
Givers and caregivers. And so I think about that time when those children between that age of birth to about 12 or 13, and you kind of have lost yourself. And then all of a sudden you be like, oh, this is my body. It actually belongs to me. And so you see these periods where we'll start exercise and da-da-da-da-da. And then, as you said, then we start to get in our 40s and 50s. We start having perimenopause or something. We have menopause. We have all of that.
Right.
The thing that has sustained me through all of those cycles is a network of other sisters.
Oh, wow. Wow.
Who I could laugh with, cry with, depend on, share, get upset, share, come back to. And all of us have always had the same message. And that is, if we take care of ourselves, will be here to take care of others.
Wow.
And so for me, I am a big spa person.
Okay.
I love going to the spa. I've probably been to over 200 spas in my life, and I probably got about another 300 to go. I just don't know where they are yet.
Okay.
And when I travel, if I stay somewhere for more than 3 days, you can bet I'm going to get a massage.
Oh, that's good.
And I've surrounded myself with a team of people who would say, now, you know you're going to stay there 3 days. Do you want me to schedule you a massage?
Right.
And it is about surrounding yourself with people who care about you and not being afraid to ask for help.
Yeah.
There's no way that I could have done all the things that I have done in my life with 2 children in this career if I didn't have a husband who cared for me, sisters who loved me, some of them blood, some of them not, and understood, and my children understand. I'll never forget my daughter said to me one day, I come home from a business trip, and they must have been, I don't know, 7 and 8 at this point, and my husband was complaining about me being gone, and I said, I'm just going to go take a walk, and my kids ran behind me, and my daughter said to me, why are you listening to him, Mama? We okay, right? And I said, all right. And I remembered this book that my lab supervisor who ran my IVF lab gave me when I was pregnant with my second child. It was called My Mother Worked and I Turned Out Okay Too.
Oh, wow.
And I had to go back to my book to remember that my mother worked too.
Yeah.
And I turned out okay.
That's right.
All right? And so if you take care of yourself, you'll be there to take care of others.
That's good. And that's a wonderful message. Dr. Montgomery Rice sharing with us, President and CEO of Morehouse School of Medicine, sharing with us today on Woman to Woman series with Juandolyn Stokes. Thank you so much.
My pleasure.
For sharing a part
Thank
of
you.
yourself.
Thank
I
you.
mean, what, in Macon, Georgia? You came
Macon,
out of
Georgia.
Macon?
Mactown.
And Mactown is still going strong.
Still going strong.
Thank you for what you're doing. You are so inspiring
Thank
and
you.
encouraging to so many. And thank you for the babies, the students that you teach, and the other professionals that you've allowed to work alongside you, and your heart that beats for research. And it continues to go on and on and go on. So I appreciate you and what you're doing. And anytime you need us, let us know.
We will. Thank you for always reaching out, and thank you for thinking of Morehouse School of Medicine and me. I appreciate you.
You're more than welcome.
Right.
Thank you for watching Woman to Woman series with Juandolyn Stokes, Dr. Valerie Montgomery Rice, right here. More to come. Have a great day.